Today's quality measure is colorectal cancer screening. As an overview, the denominator includes adults 45 to 75 years of age, and this applies to all payers. For the numerator per HEDIS, it is adults 45 to 75 years of age who had an appropriate screening for colorectal cancer screening. Appropriate screenings are defined as fecal occult blood test, stool DNA test, sigmoidoscopy, colonography, and colonoscopy. For the 2024 measurement year, it starts from January 1st, 2024 and ends December 31st, 2024. Each type differs in its look-back period. This quality measure may exclude patients who had hospice or palliative care services or are deceased, patients with a diagnosis or history of total colectomy or colorectal cancer, HEDIS notes to exclude laboratory claims for the colorectal cancer diagnosis. All of the following are required for documentation: a note in the medical record indicating the date, type, and result. A result is not required if the documentation is clearly part of the member's surgical history. Pathology reports are acceptable. Documentation can be completed during a telehealth encounter, and results or findings may be documented as normal or abnormal. Here is an example of an office visit note, but is the documentation sufficient? As circled in blue, it states colonoscopy 818 normal. It is also listed under the medical history. So we know we need three separate elements of date, type, and result. Colonoscopy is clearly listed as the type. 818 is in the month-year format and is also within the 10-year look-back period, and normal is considered the result. This document would close the gap in care. Common insufficiencies. Do not count DRE, FOBT tests performed in an office setting or performed on a sample collected via DRE. Utilizing patient questionnaires that do not capture type of screening or the patient does not provide complete information. The patient is not compliant with the care plan. For example, the screening was ordered, but the patient did not complete it. It is missing the type of screening or date. For example, col screening 119 or colorectal cancer screening is current. It is missing the findings or results, such as colonoscopy 2016 or colonoscopy is current, and these are noted within the assessment and plan section of the note, not the surgical history section. Following are relevant reporting codes for a primary care provider related to this measure. 3017F, screening results documented and reviewed. G9711, history of total colectomy or colorectal cancer. Let's review best practices. Utilize care gap lists to make patient reminder phone calls. Educate patients on the risks and various screening options. Upload reports into your EMR and label clearly for easy identification. On annual wellness visit forms, include the screening questions with all of the necessary information, such as type, date, and result. Do the same under the medical history section and office visit notes. Ensure workflows are in place to notify or remind providers of when a patient's next screening is due. Continue working with your clinical performance consultant and use ACN's additional resources. Visit Arizona Care Network's website for updated 2024 tip sheets and the additional quality measures. This concludes the colorectal cancer screening training course. Thank you for listening.